on 774 ABC Melbourne and on digital.
12 minutes to 9, back to your calls and your texts right through the morning, and still to come, there's a chase on for a meteor in regional Victoria. Yes, who's going to get there first? Oh, very exciting. Meteor chase. Love a good meteor chase. That's coming up shortly. But the Financial Review on its front page today reports that the Federal Health Minister, Susan Lee, is reconsidering Medicare's fee-for-service arrangements with doctors and thinking of introducing, I think it's based on the UK, although I'm not sure, a system where GPs might be paid per patient over, for instance, a 12-month period, regardless of how many visits that patient requires. It's a dramatic shift to try and rein in ballooning costs in general practice in family medicine. We invited the Minister to join us this morning. She's rather busy in Canberra today. Terry Barnes, though, is more than happy to talk. He's a former advisor to the former Health Minister Tony Abbott, as he then was, now Prime Minister, and he is one of the nation's leading experts on healthcare. Terry Barnes, good morning to you.
Oh, good morning, John.
Well, you shouldn't be surprised by that. It's not mere flattery, it's all the truth. Hey, we'll get to health...
I'm just the GP co-payment guy, mate.
Yeah, right, sure. We'll get to medical insurance costs, which is the other side of this, in just a moment.
Yep.
But where does this idea for an overhaul, a fee per patient per year rather than a fee per visit come from?
Well, interestingly, John, as the Fin Review reported this morning, this was an idea that was floated by the former Health Minister, Peter Dutton, before the last budget. Basically, what he was looking at, and I think without seeing the details, hard to be sure, but what I think they're looking at is something very similar, not to the UK as much as to New Zealand, where they have capitated payments for, lump sum payments for patients who are chronically ill, young concession card holders or their equivalents over there, but also fee-for-service for those of us who are casual visitors to the GP. So it's actually a blending of revenue, some from you and some from the government.
Okay, so how would it work if I'm a patient who has special needs? How does someone decide how much it's worth for the doctor to look after me for the year, regardless of the number of visits?
Well, that's a very good question, and effectively that is the crux of anything that would come into operation if this happens. And
because if you get it wrong, then the doctor misses out badly. If you get it right, then theoretically the patient can miss out badly.
Well, as I understand it, in both the UK and New Zealand, there is some flexibility around that. So it's basically a patient has greater needs than anticipated, that can be covered. So the doctor himself or herself is not out of pocket in that regard. But basically it is putting a lump sum in their account to manage the patient's care and to give them access to what the GP determines that they need in terms of specialist care, allied health care, including, say, psychological services if you've got mental illness, or just basically ensuring that they can, as the Fin reported today, that they can come back to the doctor without actually having to fork out every time they turn up. So it's focusing on quality more than quantity of service.
But it could act as an incentive for the precisely opposite result that it's intended. It could lead to a patient's mind being, well, I can go and see the doctor every day and it doesn't cost anybody anything extra, which is not what it's intended to do.
Well, that's a fair point, but I think also people don't want to go to the doctor simply for the sake of doing so. I think that's one of the things that those who debate the cost of health sort of don't get sometimes. That effectively, sometimes going to the doctor is the last thing we want to do, not the first thing. But having said that, it's important that we do manage chronic conditions better than we do, and certainly. As we have an ageing population as well. I mean, as the baby boomers basically reach the age of high care need and are going to be popping into the doctor and to medical services very frequently, we need to be able to ensure that the system itself is able to meet that demand. And but for the rest of us, those who don't go to the doctor very often, I don't see a problem with fee-for-service continuing, and I also don't see a problem with the assumption that if you can afford to make a reasonable contribution per visit, that you do so in the form of a co-payment, regardless of bulk billing.
But I've already got text messages from doctors saying, well, this will be the end of me as a GP. There's no way I would work under a system like that.
Well, we have to see the detail, and at the moment, I'm a little sceptical, not so much of the governments as much as the fact that if the reports are right, the AMA is up to its neck in negotiating this, and it's actually, and the way it seems is that it's the president of the AMA, Brian Aller, who's a specialist, not a GP, rather than the GP wing of the AMA that's actually been leading the negotiation. So if it's basically a doctor's welfare scheme or revenue scheme, then I'm concerned. But if the intention is there to look after the interest of patients better, look, I think this is something that I was actually surprised not to have seen in last year's budget rather than what actually emerged.
Well, it's a case management style. It's interesting, and it's coming at the same time as on the 1st of April, in less than a month now, medical insurance costs go up by more than 6%. Not much else is going up in the cost of living by as much as that, Terry Barnes. Why is health insurance going up so much?
Well, there are two factors here, John. One is the actual costs of providing that health care are considerably greater than the cost of general inflation, but that includes hospitals, that includes doctors, and especially those specialists who basically will sort of charge whatever they can get, particularly if private health insurance is subsidising it. But it also includes other things such as prostheses, outpatient care, even dental and optical. That all has to be paid for. But the other side of it,
well, it's understood it's always had to be paid for, but the cost of living is low. The cost of living increases are low. Interest rates are down. The economy's not travelling particularly well. This is a major slug to people, and I fail to see exactly. I can't help but link it to the privatisation of the largest provider in the country.
No, we've talked about this before. No, I don't think it has. I mean, basically, it's the other side of the equation, which I was just about to say, is demand. That basically, as the population ages and as more people take out private health insurance, the more they use it, the more of those services are bought and paid for. So so basically, when you've got that demand surge as well as a cost surge, something's got to give. What I think health insurers generally have got to do and have been doing, particularly under the public scrutiny like yours and political pressure, is to try and keep those rates of increase as low as possible. But there's always room to do more. I don't disagree with you on that.
Thank you.